On behalf of the MENA Stroke Organization, this is Hani Arif, the Secretary of the MENASO, and in continuous collaboration with the Angels, I'm delighted to present this wave of the continuous medical education sessions across the region. And we are as a MENASO, honored and pleasure to present three eminent speakers. We will start by our dear colleague, Dr. Mohammed Aljohani. He is a consultant stroke neurologist, neurology department, King Fahd Hospital, Medina Neuroscience Supervisor, Medina Regional Stroke Lead. He's a consultant neurologist, vascular neurologist, and director of Neuroscience Center in Medina. He will talk about the lesson learned from stroke in Medina. Please, Dr. Mohammed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Prof. Hani, for your introduction, and it's an honor to be with you. I would like to start with thanking the organizing committee, Dr. Rokin, Dr. Adil, and you, Dr. Hani, for sharing this session. And I would like to start this by mentioning that I actually have been Vice President for the Saudi Stroke Society, so I'm glad to be here as well in the MENA. Well-being, mental well-being, and physical well-being, and going to virtual care, primary care, general hospital care, and specialized. How would you build a stroke network? You co-build with the patient, build around the patient needs, and you focus on quality, better outcomes, better experience, and definitely something that will attract the admin and the hospitals is this cost. It is the time of system. So in the 20th century was the century of the hospital. 21st century is the century of system. Stroke is complicated and complex. Complexity can be managed not by focusing on smaller and smaller elements of healthcare, but looking at the problem as a whole and the relationship between elements. This is what's meant by taking a system approach to healthcare. There was a pilot study that I would like to mention here. The pilot study was in Saudi Arabia, 5 months of close collaboration, regular weekly meetings, and 2 full days of working sessions. They came up, the idea was to look into cost effectiveness of developing a good stroke program in the kingdom at a national level. And they looked into the cost breakdown, increased number of ischemic stroke that will be increasing with time, looking at the population and the trajectory of these growth. And they looked into clinical improvement of acute ischemic stroke by providing the acute interventions, including mechanical thrombectomy and thrombolysis. And you can see that we looked into the whole regions, how many that we need, the neurologist, the neurosurgeon, internist, radiologist, all that involved in stroke care in different regions. And we looked into what is the population in these regions and what are the number of stroke expected and how many beds we need in these areas. So it was a beautiful exercise that we did with our colleague. Today, current stroke care organizations will look at 18,000 first-time stroke per year in the kingdom. This was in 2018. 5% of patients got admitted to a stroke unit. Annual rate of IVTBA nationwide, national level is 3.3. Mechanical thrombectomy annually less than 100. In the future, the target is to get 95% of patients admitted to a stroke unit, to increase the annual rate of IVTBA 24%, and to get more mechanical thrombectomy, about 5,000 mechanical thrombectomy. Comparing that, we'll have 67 to 57 to 67 increase over 10 years from 18,000 to 30. And we looked into the cost impact of changing hospital organization of stroke care, early discharge to a less expensive facility, reduce hospital cost. And this is now and then. So it is actually looking at the direct cost, it decreases by 34%. So this has been translated with our colleague into papers. We had the National Economic and Clinical Model for Ischemic Stroke Development in Saudi Arabia, and we looked into the cost effectiveness, and actually we will save about 2 billion over 10 years. So looking at the epidemiological model for first stroke in Saudi Arabia, we found that about 50 to 67% will be increasing within the coming 10 years. We don't need that much of workforce, to be honest. We need 390 healthcare workers in the whole kingdom, and this is for a very specialized people. The Saudi Stroke Project has actually led by Dr. Fahmi and the colleagues, and involved even patients in this process. They put values: patient first, equality of access, value-based healthcare, networked staff, institution, best clinical practice, and embrace innovation. And has been translated to Saudi Stroke pathway standards. And this is how these KPIs and these standards looks like. You have computation method, the statement of the KPI, numerators, denominators, and the reference benchmark, what is minimum acceptable, good, and excellent. And you can see that they focused on the main things when they are looking into 13 KPIs as the priority KPI, but there's a lot of other KPIs that you could look at, especially if you have advanced level of stroke care. These are the proposed hospital classification. And if you looked into the proposed hospital classification, mainly 3 hospitals: comprehensive stroke hospital, primary stroke hospital, and acute stroke ready hospitals. Here what is unique actually that telemedicine capabilities has been looked at here, and it is actually needed for those in comprehensive stroke centers to provide telemedicine. And those primary stroke centers, you need telemedicine, especially if you don't have a stroke neurology or neurology site. An acute stroke ready hospital, you need it if you are more than 60 kilometers from the hub center. And to look at which hospital that, which classification that your hospital will be. And we created, or our colleague actually created, a stroke readiness assessment tool that we used it in Medina by assessing the infrastructure of these hospitals. And this is the task that we had. We had the Medina Stroke Network. We have a proposed task. It is over. We did actually put it over 2 years, so we are still growing, and we put a target to put a comprehensive stroke center, primary stroke center. We look into the distance between these hospitals. The task that we had 2.1 million population in the Medina region, 18 hospital, IVT Bay at 1 hospital service with variable availability, no funding. So you have to do it with no money. We have the resources to have primary stroke center, and all hospitals can be easily acute stroke ready hospitals. So you need to understand the actual state before any improvement project. And this is actually goes to a lot of regions in the kingdom. We had 1 hospital that has IV thrombolysis with no code stroke, because they have early referral to a neurologist that will come early on. We have 6 neurologists in the hospital. Other hospital has missing services. So some of the hospitals do not have MRI. They do not have a cardiology service. Some of them, they don't have rehab or physiotherapy. Even some remote hospitals do not have a CT machine. So no actual pathway for a stroke existed as well. Patient arrived with the stroke symptoms will be evaluated by emergency and referred to internal medicine. Then if the patient above the age of 48 will remain under medical services in that hospital, regardless of lack of services in this hospital. If patient below 48 is accepted by neurology based on bed availability. So in a very crowded hospital that have a trauma center and have a lot of specialties, you will have difficulty in getting the patient. No stroke unit available at region. So steps that has been done. First step was a proposal for a stroke network was submitted and approved by regional admin. Stroke service line was approved. Leadership and project manager was assigned. Committee of multiple specialty and stakeholder was formed. So we got the head of department of internal medicine from each big hospitals to be with us, and including the urgent care model lead from emergency, nursing, social. We involved a lot of specialty. So we did the readiness assessment. We did site visit and engaging stakeholder at the hospital level. By the committee, hospitals were classified based on the infrastructure Sometimes even the infrastructure is difficult. We look into geographical location. So there are areas in the kingdom, in Medina, that it is away from the hub center by 380 kilometers. So geographical location is very variable. We did the stroke rota for neurologists, covering the whole region for stroke in window and stroke referral in general by factors. So stroke pathway for each level has designed, creating code stroke at each hospital participating, and making sure that all participating hospital has privilege for all neurologists in the rota, and active-based management with protocols for thrombolysis and management of complication available at the stroke for stroke patient at the hospitals. Training in pathway protocols and even training in use of delayed stroke. So what we did, we built a stroke unit. They didn't give it to us, to be honest. We had to fight for it. And we started with a mobile team first, just to know how many patients are admitted. Then I took the hospital admin and I told them at any time, you'll find between 16 to 18 patients in the hospital are stroke patients. You just need to put them in one geographical location, then to talk about protocol and policies. So we got 10 beds. Then when we launched the service line, we got the 25-bed stroke units, which is the largest stroke unit in the kingdom. And we had another stroke unit that actually is remotely been utilized. Just we visit that unit one time a week, and we provide opinion through telemedicine or mobile sometimes based on the availability. So we had another stroke unit in Yamba, which is 4-bed stroke unit, a small one, just to serve that population, because they are at 280 kilometers and they have about 500,000 population. So the 5 hospitals are connected to the Angkor Rota. In the beginning, we get help from our colleague from Jeddah, from Mecca to be in the serve, because they actually donated their own time to be in the Rota in the beginning. Then we transferred that responsibility to neurologists in Medina. Those people were a stroke neurologists in the beginning. Then we transferred to neurologists in Medina. Protocols are built in and code stroke established in these participating hospitals. Access to medical imaging through the software. Training is being done through telestroke. So we are using the same telestroke to provide it. And you can see this is my colleague, Dr. Majid Bakhit. He's from King Abdullah Medical City, and he's a stroke neurologist leading the Ministry of Health part of non-clusters hospitals for stroke lead. And actually, we get a lot of help from all colleagues, not only from Dr. Majid, but we are testing here the telemedicine, and these are 2 different hospitals in Medina. We had our own creation. So we got a stand, we did an iPad, and we have chosen software that is FDA approved, and now currently is Saudi FDA approved for use of telemedicine. It is actually joint application that we use. So you could have a fancy stuff here that if you have the budget for it, you could get it, and a robot that moves around and get things more accurate, zooming and so on. But we got based on the compliance with HIPAA. So we got the minimal things with less cost, but providing almost the same view. Mechanical thrombectomy was an issue. We were unable to do it in Ministry of Health, but we didn't stop there. There is a Halati program. It is in Ministry of Health. It is a great tool that already we have in place. It might take a longer time, of course, but we developed some transition. You could imagine that any patient from governmental move to private hospital if the patient need a mechanical thrombectomy. Sometimes even we are bypassing the hub center, go directly to the private hospital. This is the team led by Dr. Basim Sheikh and the private hospital. Rehabilitation services were a big thing. We have only one hub center. Other are fragmented, except for Yamba General Hospital. Medina Rehab Center is 100 bed. It is a very big hospital, but it is more of a hospice than a rehab center. With time, we have now actually a dedicated stroke beds. We never faced a problem since we started the program. They want to have more active beds, and we want to provide for our patient more rehabilitation. Working collaboration with our colleague to have more active beds. Now we've from actually we achieved what we are trying to achieve within 5 years. But of course, we aim higher as well. This is the stroke network. You can see that we have a joint app user that they can communicate through us. There's phone calls, so the people can call us. Most of hospital has a code stroke. It's a unified in-call rota for the surface line. If patient requires perfusion therapy, IV is TBA is delivered at the site with telemedicine. So the problem of transfer, we overcome that with regarding thrombolysis. And if patient is MT candidate, patient shifted directly to MT capable center. Every stroke patient is admitted to stroke unit. They fit the criteria. So there are 3 hospitals in Medina that admit stroke. No other hospital allowed to admit stroke. Of course, there is an exception. If the patient requires ICU, there is an involvement of the ICU surface line. And if the patient is bed-bound, bedridden, and came with a stroke, will not fit this in our stroke unit. These are represent about 5 to 10% of all stroke patients. No admission is allowed in acute stroke-ready hospital to make sure that these patients receive appropriate therapy and appropriate assessment as well as rehabilitation and so on. It was a very big task because you are bringing the whole strokes in Medina to all the 3 hospitals. You need to support them. Through stroke exit pathway, every patient must be assessed by rehab services. Now we have, I mentioned King Salman Medical City, which is actually a new medical city that we have in Medina. We have established a new neuroscience center with a new neurology department. So you could see it was easier before because we had one neurology department. We could talk to those people. You are covering the stroke. We don't have except you guys, and you're gonna do this task. Now you have 2 hospitals that we need to look at how we can use it. And this model can be used for if you have a neurologist that does not cover 24/7, just maybe one neurologist at one hospital, there's another neurologist at another hospital. So you could join them in one rota where they cover, and the one that will be covering the call will receive the patient to the hospital. So this model can be used in hospital where neurology service is not available 24/7, meaning that the hospital A has one neurologist or internist, hospital B has one neurologist or internist, hospital C has all can share in the expert 24/7. So there are things that discussed with our colleague and hospital admin during starting our project. It's not. I'll be honest. We had these questions and they were given in front of you of all admin and all meetings clearly. We don't have a stroke unit to start stroke service. This is the first questions. We cannot give thrombolysis because we don't have a stroke unit, which is not true. You could have some of the services. Just start with whatever available you could make in your own hospital and your region. We don't have a neurologist. You do not need a neurologist to manage stroke. Stroke management is not only about the neurologist, but nursing, protocols, internist. If you ask internist how many thrombolysis you give for a MI, they will say a lot. But how many thrombolysis you give for a neurologist? You for a stroke, you wouldn't find a lot of internists giving for or emergency physician giving thrombolysis. Just be clear, give them the protocols and educate them about those clear patients that come in the window. And of course, privileging. Most of the hospitals, there is no specific privileges, up to my knowledge, for thrombolysis in our hospitals. But in those big hospitals, there are actually a special privilege if you have a neurologist. If you don't have a neurologist, then either emergency or internist need to play a role here. We don't have interventionists. Again, this is one service. Focus on the main services and whatever you could do for your stroke victims, do it. We do not want more patients in our hospital. We are already crowded. This is a very common thing, especially where I started. Clearly, we are a trauma center. We don't want any more patients. I told them, no, actually, you are going to receive the facts anyway, and you're going to discuss this patient to be accepted, and you're going to say no beds, and the faxes will keep bouncing back until you accept the patient. Now we do some kind of triaging these patients. You make sure that you want to bring the right patient. And this way, we actually convince the admin to bring the patients, more patients to the hospital. We don't have more beds or units. As I mentioned, I convinced our admin by taking them over the hospital to look how many patients are actually using beds and they are diagnosed with a stroke. We do not have enough staff. Start what we have. If you don't have a nursing staff to cover a stroke unit, 1 to 2 or 1 to 1, you could have 1 to 4, 1 to 5, and divide it into HASO and HASO. There are different models that you could use with existing staff, but of course, you don't want to sacrifice quality for quantity. The key points: build a great central team, aim, standards, rollout plan, involvement many entities, and Ministry of Health, Saudi Health Council, SIBAI, FAB, get buy-in and by painting a convincing story. So this is what we're doing for Medina now. It is a convincing story that we could make it in every region that have a deficit in stroke services. Communicate. So we did a lot of communications. I visited almost all hospitals in Medina region, 18 hospitals. I have visited most of them, and I get to know the medical director, the internist that working there, the emergency. We got over a year. I mean, it's not over a month, and we decentralize implementation. So you want these people and these hospitals to own stroke program. You don't want the one that moving the everything from your side. You want them to be involved in implementation as well. Focus on widely important things. So, for example, you want to look at admission to stroke unit. You want to look at antiplatelet. You want to look anticoagulation for atrial fibrillation, the rehab, the prevention of falls and bed sores, prevention of urinary tract infection and respiratory infections. There are a lot of things that you can do without focusing on IV thrombolysis alone and on mechanical thrombectomy and having a stroke neurologist in your hospital. Develop and share scored KPIs, create accountability. And these are the people that I would like to thank. As I mentioned, I didn't do it alone. I reached almost to a lot of stroke neurologists in the kingdom, and these are the big names that helped me actually during establishing the stroke program, and I still do. And I still call them for help and advice regarding what to do next. Of course, I would like to highlight that we are still struggling. Sometimes when you have a lot of COVID cases, the admin push you to take some meds, and you are doing your best, but you compromise when you can, and when you cannot, you stop. The telemedicine are being reviewed, but we don't have a problem. Just a few legal stuff that we need to go through. So there is actually always things that to do and always challenges to overcome. And thank you, and thank you, Dr. Hani, for the chance.